Okay, so you heard my title. I'm from Food, Water, and Environment, but what I was asked to talk about today is actually from my old job at the CDC from the Division of Healthcare Quality Promotion. So I'm going to switch it up from all the other discussions we've had so far and talk humans and healthcare-associated infections, and just to sort of spark the conversation about how at CDC, first of all, how did HAI reporting come about? What was the importance? What sort of started that pathway? And then how did we address it from that human side and from the healthcare side at CDC? It's not to say that this is what needs to be done on the animal side at all. It's just to say what was done, could anything be copied, could anything be used, and to spark the discussion and conversation when Rick presents to sort of compare and contrast to say that wouldn't work, that might work, maybe something similar. So why HAIs? Healthcare-associated infections have been a problem in hospitals, healthcare settings for years. And CDC and hospitals have been trying to monitor and make changes to improve patient care and safety. When I talk about HAIs, I'm talking about things like central line-associated bloodstream infections, catheter-associated urinary tract infections, things that happen in multiple different healthcare settings based on what the patient care is. And we'll go into those settings when I talk a little more carefully about the National Healthcare Safety Network. So, HHS Steering Committee for the Prevention of HAIs was established in 2008, knowing that this was becoming a problem. People were dying, they were going into hospitals and healthcare settings and coming out sicker than when they went in. So there was HHS developed an action plan to prevent HAIs and started this roadmap for HAI prevention. And the first focus was in acute care hospitals, and then the idea was it should expand to all the healthcare settings where people could potentially come in contact. So 2008 is actually when I joined CDC and DHQP. So I sort of jumped in right when all this started happening. So what was the reaction when this roadmap went out? And again, I have 15 minutes, I have to move through, so I'm going to try to stay at a very high level. But when groups like the federal agencies, state health departments, and healthcare systems and corporations saw this, they said, what are we going to do about it? Do we want to wait for someone to tell us what we're going to do, or do we want to move ahead? So state health departments started looking at their own legislative capabilities and said, maybe we should start mandating some reporting of HAI so that we know what our hospitals are doing and what it looks like in our state or jurisdiction. Federal government said we need to start responding to this as well. So Centers for Medicare and Medicaid Services started talking about how will they legislate and mandate and put rules forward for start mandating reporting. Healthcare systems on their own, whether it's smaller systems, larger ones, or corporations like large dialysis corporations, for instance, started saying how would we mandate what is important for us and what HAI should we start looking at from our space. And in all of this, CDC, which doesn't regulate, said we have the National Healthcare Safety Network. We had a low number of healthcare systems already using it for voluntary reporting. They were putting data in so they could get the data back out and do some comparisons, and using it basically as a surveillance platform because it offered a way to collect the data systematically, and then we had analysis built into it where they wouldn't have to figure out their own analyses. They could run it from there. So from that, basically, there was this decision to say it's a good platform. Let's try to use NHSN. It wasn't perfect. It still isn't perfect. But it was enough of a platform to say we could grow it from there for this reporting. And then we had to start considering what did we need to do to make it better to meet the needs that were going to come from these mandates. So the idea was to look at being able to identify the infection prevention problems, having something that would offer benchmarking at different levels, a facility level, state, jurisdiction, and national, complying with state and federal public reporting. So we would change the system based on what would need to come in so that individuals would just have guidance on what they were supposed to be reporting. And again, driving this national progress, which was the whole point, to try to decrease HAIs in the healthcare setting and make patient care safer. So NHSN grew and the reporting grew. It started with acute care hospitals, Then long-term acute care hospitals were mandated and came on, and we expanded. Critical access hospitals had separate reporting and had special needs for how they would report. Psychiatric, rehabilitation, outpatient dialysis, ambulatory surgery, and skilled nursing facilities and nursing homes. So when you look at this list, the important takeout from this is that these hospitals and centers are all different. And again, for me, when I look at it and being in the space I'm in here, I think of, comments about, well, the animal species are all very different, so things have to be addressed differently. This is the equivalent on the healthcare side of these settings are very different, and the patients that go in and the care they get are very different, and then how do we address that with the reporting that they would need to do. This is just to show the exponential growth that hit. So if you multiply the 3 by 100 and the 170 by 100, it really went from 300 hospitals reporting in 2008 to over 17,000 facilities reporting by 2015. And it continues to grow. But 2015, it already had hit 17,000. That's individual facilities. So multiply that by 2 or 3 because that's at least the number of people from each facility that end up putting data into the system from each of those facilities. So it gives you an idea of the size of NHSN and the amount of data coming in. So this is the important slide. When these mandates and these decisions were made, what were the concerns of the healthcare facilities? Because this did not happen smoothly. And facilities were not happy. They had a lot of concerns. This was brand new. They didn't know what to expect. And there was going to be a lot of change coming forward towards them. So the main issues they had were staff burden. What would it mean to put these data in and meet these requirements? And what would be the consequences all of a sudden of having these data that they were used to having in their own systems and managing all to themselves somewhere else being managed outside of their own system and being combined with other facilities. So security and confidentiality of the individual patients and their data as well as the facility level data. Required data elements that they weren't currently capturing. And so, for instance, if we said in one of the definitions you had to know if the patient had fever or not, so you had to know temperature. Well, they would say, well, we take the patient temperature, but there isn't an exact spot in the medical record to go in and look and find it and pull it. So that's going to be very difficult unless we change our system. Manual data entry. So now all of a sudden there was going to be more data elements to meet criteria that they were going to have to put in. So time consumption to collect and enter as well as the potential for data error. This, for hospitals, fell upon the infection preventionists because they're the ones within at least the acute care settings that do the surveillance for HAIs, infections, and antimicrobial resistance. So they actually had a unique pressure and space that they were in because all of a sudden there were NHSN definitions to say, is this a central line associated bloodstream infection or not? But a clinician that worked there for 40 years said, I never called that a CLABSI. That one should not be a CLABSI. So they would get in arguments with their own staff saying, no, we don't want it counted, it's going to make us look bad, don't put it in NHSN. And then us saying, it's a federal mandate, you have to put it in, you have to follow the definitions, it's a CLABSI. So they were caught in the middle of some odd situations. There was a concern about validation. So if I'm a hospital that's looking for everything and being honest and putting everything in, but there's another hospital that doesn't really look as deeply, so maybe then they don't find, well then they look better than me. And that's not fair because we're doing our job and we look worse. So then validation had to come in and there was an extra level that had to get put on to make sure that hospitals were reporting and everything was fair and to be compared. Consequences of publicly reported HAI. So what's the potential negative on a hospital? They're going to look bad. It's going to look like it's dangerous to be in that facility. Our patients getting sick and dying. Then they're going to lose business and the hospital's going to close. So those were a lot of serious concerns. There was also a long ongoing conversation about the expectation of getting to zero. Were these HAIs all truly completely preventable? And should you actually be able to get to zero? And it wouldn't be a success unless you actually hit zero. So that's sort of where we started. I'm going to go through now some of the things that we were able to do to deal with it. things with the NHSN system, and this probably was the easiest thing to deal with, as far as making it secure. We use the SAM Secure Access Management Services, where you can't even log in and get a card to be a part of NHSN, to put data in and have access, unless you go through, we'll just call it a little mini background check. And that's to make sure that the individual worked at the facility they were being linked with, and that they actually, for instance, their driver's license and their address matched the address where the card was being sent, so the person was who they were supposed to be to get access to the system. We worked a lot with HIPAA in that people were worried about the rules. If HIPAA is enacted and it's in place, we might not be allowed to report patient data into the system. As a hospital, we can't share the data. In fact, they can, because it's public health surveillance for the safety of the public, so they were allowed, but they took a lot of convincing and worry about were they breaking rules if they were reporting into the system. When a facility goes in and sets itself up, there's an agreement to consent. The C-suite at the hospital, the leaders had to sign to say, yes, we want to be a part of the system and we're going to go in. And there was always only one facility administrator that actually owned that facility and the control of who would be able to be in the system representing that facility and what roles would they have as users. Could they enter data? Could they edit? Could they just look? Could they analyze? So a lot of control by each facility and the user as to who goes in and can touch their data, because you can only see your own. You can't see other data in the system, except for group users. And that was a second level built on, where if I'm a healthcare system and we have 8 hospitals, we could form a group, and corporate from our hospital then could join the group, and we would all agree to share certain bits of data. Then that corporate person could come on and see the data we've agreed to share, so they could run analysis across our whole system. State health departments could also join as groups and things like that. Data elements. So there had to be a set of data elements that everybody agreed with. And again, this didn't happen overnight. We had definitions we had to work through. We had clinicians who would give input. We had a lot of groups and organizations that we would meet to say, for this infection, what's the most reliable definition that would be accurate, that we could collect data on and actually get it reported in a timely way and make it realistic and make it comparable. So specific data elements that would meet definitions. And so each data element then had a definition so that people would know what we were looking for and what it meant to put that piece in. In addition to that, we started looking at it's going to take a lot of time to do this manually. So while we knew there was going to be a lot of manual data entry, we also wanted to help facilities to move electronically if they had the capability. So we used the Health Level 7 international standards and format, so that if hospitals were going to move electronically to reporting, everybody would be on the same platform, so that data can be interchangeable and interoperable from an acute care to a patient transferring to a nursing home and out to rehab and maybe back to acute care. The last thing on that was metrics and the comparison of the data. So CDC didn't just make up the analyses that would happen and say, this is how you'll analyze and this is how we'll compare you. The National Quality Forum is actually a nonpartisan membership-based organization where they have an application for a metric. And so we would fill out the data for how we collected at CDC and what we think a good metric would be. And again, we worked with individuals and professionals and organizations outside of CDC, but we would submit to say, this is the best way to measure a central line associated bloodstream infection. And this is how we would track it and trend and compare over time. That metric then goes through a whole approval process and gets NQF approval. So that then CMS would say, this metric is NQF approved and we want hospitals to report and we will compare by this NQF approved metric. So a very standardized, organized way to get agreement across groups to say that is the best way and the fair way to compare us when you're going to be comparing like hospital to like hospital. So the benefits of the healthcare facilities, it's internal and external motivation. And I think they've grown a lot with the benefits that we've gotten from the fear that started in 2008. So we have standard data, there's established metrics for meaningful comparisons that we see over time. There's internal levels to strive towards as each healthcare facility inside has a lot of analyses and reporting and metrics and reports that they can just hit buttons, run their data, take it to their admin staff and do comparisons. It makes it really easy for them to be able to use the system and get their data back out. They've been able to identify risks from their practices, the processes, from other transferring hospitals to be able to come up with prevention processes and measures and infection control that they didn't think about before. Things like central line insertion teams that carry a bag around, and they're the only ones in a hospital that insert central lines now, and they're the experts at it. Decolonizing patients or putting them on contact precautions. A lot of things have grown from finding the infections and then being able to have the data to dig what can we do to make it better, showing that that process actually works, and then spreading the word and having more uptake for the decrease of HAIs. So again, measuring success and showing it. Turning potential negatives to a positive. This was a huge thing where hospitals were afraid if it showed that they had infections, nobody would come to them, they'd be ostracized in the public, in the newspaper, and then they would shut down. Well, what they started doing was owning it. So they'd say, you know, we've identified this practice in the surgical procedure, and now we've changed it. So we've seen our infections in the surgical site infection go from here to here because we improved our process. So turning that into a positive success story where they showed that they owned it, showed that they created a new infection process and measure, and then showed the success by showing their numbers go down. External benchmarking to facilities to know where they stand nationally and to identify if they do have a problem. We have seen reduction in HAIs over these years, a tremendous amount, and again have shown that we have healthier and safer patients for it. So finally, this is just to show at CDC when we present the data, the patient safety analysis resources we do, they're still doing, every year they do an integrated summary report by national. So those data go out nationally for the HAIs, for antimicrobial resistance by pathogen to look at what we're seeing in NHSN. Now, the atlas that you see on the right-hand side with that graph is interactive. So you can actually go in and look at the HAIs and the antimicrobial resistance that CDC has seen reported from healthcare facilities. You can pick a pathogen, pick a resistance, pick the drug, and look around to the data. It's all available publicly. But you can only look by state. So we don't let it go down where you could actually figure out a particular hospital. So there's low-level numbers set into everything so that if, for instance, you're talking about Delaware and there might be only 7 or 8 acute care hospitals, there's certain numbers that have to be in before the data would be shown outwardly so that you couldn't guess that it was a particular hospital. And then finally, by state, every year CDC puts out and updates their HAIs and the antimicrobial resistance by state. So again, stays at an aggregate level. So that's what I have, but again, hopefully it'll spark discussion on this is what was handled for the required reporting nationally for HAIs, and antimicrobial resistance and stewardship is being built into NHSN. It's already in, and that uptake is starting to grow as well. So it is probably the biggest platform we have at CDC for tying that all together on the human side. So thank you.